Hi everyone, I am Dr. Ruchi Raj. I'm your Prosthodontics mentor at DBMCI MDS and I welcome you all to the discussion of NEET GT12. Let us start with the first question. Most reliable landmark for determining occlusal plane in complete dentures is what? So the question here is asking what is the most reliable landmark out of all four of them? One thing which you need to consider here is all four of them can possibly be different landmarks for identifying the occlusal plane. But when the question asks most reliable, you have to identify which is the most reliable one. The options given are allotragus line, commissure of lips, hamular notch, and retromolar pad area. Now, the decision-making process here is determined by what all factors. When we say most reliable, we want to see which is anatomically one of the most reliable landmarks, which does not have a lot of variations. Second, which is easy to identify for us, or even as a simple student also, and something that gives you the whole picture by even just one landmark. Now, when we look at all four of the options, we have allotragus line, commissure of lips, hamular notch, and retromolar pad area. The correct answer here is retromolar pad area. Now, I'll explain you why. When in a side view in mandible, we have our retromolar pad area like this. You just divide it into three halves. Divide it into three halves, and the junction of upper 1/3 and the lower 2/3, which means this plane or this lane will be the reference for your occlusal plane as a whole in general. When you have your allotragus line, it just helps determine the level or plane or the parallelism of your maxillary occlusal rim. Commissure of lips will help you just determine the level of the mandibular anterior part of the occlusal rim. Hamular notch will help you just determine the extent of the denture base. It has no relation to your occlusal plane, but your retromolar pad area will be rather the level of the junction of anterior, this 2/3 and posterior 1/3. That level will help you determine what is the exact level of your occlusal plane. So first question answer will be D. Now, second question, classification of this particular case is what? Now, Kennedy's classification is quite a repeated topic and is asked probably a lot of times in our exams in one way or the other. The various ways where Kennedy classification can be asked to us is what? Either they give you an RPD and help you, ask you to identify it, or they straightforward show you the edentulous area. Now, when they give you an RPD, it becomes a trick question if you have not studied your Kennedy classification very well. Why? Because you are not seeing the missing area. So there's a visualization issue here. So I'll suggest you wherever is the RPD, you have to just cross those areas off and now visualize the cast as a whole. And what do you see? You see one edentulous area over here, which is a unilateral distal extension area, and you see one tooth bound area, which is your modification space. So the answer naturally and now easily, with the help of Applegate rules, will become Kennedy class 2 modification space 1. Now, if I were a student and I did not know this answer 100% with certainty, or probably I had some doubts, what are the ways where I can identify still or take a guesswork here? My best bet to you here is to see all four options, and the least you can probably know here is that there are two edentulous spaces, so one of them has to be modification space. Now look at all four options. There is only one option with a modification space here. That is option number B. Rest all of them are straightforward, 1, 3 and 4 only. What does that suggest? That B is your straightforward answer. So this is how you take your guessworks also. So question number 2, the correct answer is option number B. Now, let us come to question number 3. Primary purpose of tissue stops. Primary purpose of tissue stopper or tissue stops in special tray is what? To improve retention, to ensure the uniform space, to reduce the pressure of impression, and to improve your aesthetics. Now, when again, like as your first question, I'll want to highlight one thing. Why? Because when we do a doubt solving on our groups and in other places, we see that a lot of students will immediately take a screenshot of this, put it in the group and say, but then this thing is also one of the purpose of it. Why not that is the answer? So here, students, you need to understand one thing. When the question mentions primary purpose, most important, most reliable, it is stating to you very clearly that all of the other options may possibly be also functions or roles of that particular item, but they may not be the primary or the most important one. So here you have to identify which is the most important or the single most important role of that, which would be what? Tissue stoppers are given so that the thickness of the impression material is controlled. The moment you don't give a tissue stopper, there is uneven thickness of impression material. How? For example, this is our ridge, and let me draw I'm showing you a cross section here, your special tray over here, and these are my points of tissue stopper. I have given a 2 mm thickness of tissue stopper. The moment my tissue stopper comes in contact with the ridge over here, this is the only amount of material that can stay in between. Rest all will come out through escape holes like this that we have on our special tray. So this is the first and primary most important role of tissue stop. So correct answer to this question will be ensure uniform space, right? After this, there are other roles of tissue stops also. What? It helps you align the tray in the correct position. Throughout your body molding, you had your spacer, which was in intimate contact with the tissue underneath, and that helped you align and locate the tray in its correct position. The moment you remove your wax spacer, now there's a gap between the tissue and your special tray. So there's no particular position in which you can rather seat. There are multiple ways in which you can seat it if you do not have tissue stopper. If you have a tissue stopper, it will guide the tray into the exact position in which you have done your border molding. So the correct orientation of the tray is also maintained. These are the two main important roles of your tissue stopper, but the number one important role is to ensure a uniform space. Come to question number 4. Patient gags during maxillary impression, best modification that you can do. So here we have a gagger or a gagging patient during maxillary impression. Best modification you can do. Now here also I'll give you one more tip. The question is asking you best modification. That means it is expecting a clinical intervention from you or a clinical tip from you. So when the question probably states that either give medicine to the patient or something like that, probably that is not what the examiner is hinting at. So let us look at the options. Increase in the tray size, it will lead to further gagging. Using a fast set material, yes, we can do that. Extend the posterior border, again, it will lead to more gagging. Increase the viscosity. Now, when we increase the viscosity, chances are that registration may not be that accurate. So, the most accurate answer over here is to use a fast set material. And this is actually a commercially or a rather a clinically used method. We use fast setting alginates because generally alginate is something with which patients have a lot of gagging if they are not correctly mixed. If you have a very liquidy mixture of alginate that is going out of the posterior border, probably that can creep into your soft palate and lead to gagging of the patient. So in that situation, when we have a fast setting alginate quickly into the patient's mouth, it sets very fast, you can take it out, and generally patients are able to tolerate it well. Now, what are the sequence of managing gagging in our patient? So when we have patients with gag, the first thing we do is most important. A tray adjustment should be accurate. Despite a patient is gagger or a non-gagger, tray adjustment should be accurate. That means it should end at the hamular notch. It should not extend further beyond that. Second is material selection. Select the correct material and rather mix it probably in the most accurate manner with the correct water is to powder ratio. You can even change your material setting by modification of accelerators or doing other ways. Example, using warm water or something like that, or a warm slab also. So these are different ways. Pharmacological means of managing gagging when these things don't work for our patient is to spray local anesthesia in the palatal region. That area is numb. The patient does not feel it a lot and probably would be able to tolerate it. Sedating is the last option and generally not preferred. Then there are better variants or option is to use a scanner to make an impression. That is rather easier. Now, let us come to question number 5. Platform switching implant concept. What is the primary advantage? So there is a concept in implantology called platform switching, and what advantage it offers. Does it increase the implant length? Does it reduce the crestal bone loss? Does it offer better osseointegration, or it increases the crown height? Now, if you don't know this concept, probably it is difficult here to take a blind guess in this particular topic. So what platform switching essentially means is that, for example, you have a fixture like this. Then the abutment also that comes over it probably will be of the same width and the dimension. But if your fixture is the same fixture, the abutment that comes over it is narrower, and it offers you an additional platform or a space. Eventually what happens is bone grows in this region. It is considered that the crestal bone grows over in this region, and it helps preserve the crestal bone, and the crestal bone loss is reduced. So using a smaller abutment in comparison to the fixture diameter offers you this advantage, and this concept in toto is called as platform switching concept. So here the answer is it reduces crestal bone loss. These are the different options, and correct answer is option B. Now, does it increase implant length? No. Does it increase crown height? Actually, increasing the crown height is generally not preferred because it will have leveraging forces on the fixture. Does it offer better osseointegration? No. But in all of the options where you feel that the implant surface is modified in some way, will eventually lead to better osseointegration, because surface treatments are generally aimed at that. So if the question mentions anything regarding a coating or a surface treatment, keep it in mind, it will be regarding osseointegration, right? So question 5, our correct answer here is option number B. Now, features of stress breaker in distal extension RPD are what? It reduces torque on abutments, it allows controlled movement, it increases the rigidity of clasp, or it protects the supporting tissue. Now, what exactly is a stress breaker? So, a stress breaker in distal extension RPD, what is it? Let us put it down over here. So, stress breaker. What exactly will a stress breaker do? When we have a distal extension case like this, right? A stress breaker basically breaks the junction which is there in between the direct retainer assembly that will come over here on the terminal abutment and the denture base that comes over here. So it provides a hinge-like junction, or should I say a flexible junction between this. By doing so, what do? You are reducing the leveraging or torquing forces that may possibly come onto the abutment. So first thing that it definitely helps is it reduces the torquing movement on the abutments. Consider it like that. When you're moving through a train and there are different bogies attached to it, do you see the connecting channels or links in between? Right now, if it was one complete rigid connection, imagine the amount of force that goes onto the engine also, and there is no breakage where the stress can be dissipated. But if you see a running train moving between these bogies also, that hinge will move like this, and when it moves like that, there is dissipation or breakage of stress also that is generated, right? So that happens here as well, that when you give that hinge-like junction or a flexible junction between the direct retainer and the denture base, that in itself is called as a stress breaker. It is difficult to construct. It is not an easy thing to construct. It is difficult, but it reduces the torquing forces onto the abutment. Second, definitely allows controlled movement. So even option 2 is correct. It does not in any way affect the rigidity of the clasp, and it in a way protects the supporting tissue. So correct answer is option number A, B and D. These are the features of stress breakers in RPD. Now question number 7. Most accurate articulator for full mouth FPD rehabilitation is. Now again here the same thing that we have discussed earlier. When it says most accurate, Can you do it on a semi-adjustable? Yes. Can you do it on a fully adjustable? Which one will be most accurate? It would be fully adjustable. Why? It conforms to all of the dimensions of the patient. You can do as specific modifications of even the condylar fossa shape onto the fully adjustable articulator. So it will be definitely much more accurate than semi-adjustable. Now, let me make a modification in the question here. For example, if I ask you, most commonly used articulator for a full mouth rehabilitation is what? What will be your answer? Semi-adjustable. Why? Very commonly used in day-to-day practice by all clinicians. Hardly people use fully adjustable. Again, if I ask you a question for your full mouth FPD rehabilitation is, out of all of this, which will be least technique sensitive to use for FMR? Again, answer is semi-adjustable. Why? There it will confuse you because you'll feel that mean value is easier than semi-adjustable, but can it be used for FMR? No. So mean value goes out of the question because it cannot be used for FMR, but semi-adjustable and fully adjustable are used. Out of that, least technique sensitive and easier to use and rather very commonly used is semi-adjustable, but the more accurate one will be fully adjustable. So read your question properly. Whenever you are attempting your answer, most of you have the knowledge. It's just that you don't read the question properly. So read it well. Now, question number 8, an image-based question. Most common cause of what? They are trying to show you something out of the picture, which is what? There is chipping of porcelain, possibly on an implant crown here. Is it a cement failure? No. Is it occlusal overload is responsible for this? Poor bonding or implant mobility? Now, we know that there's no bonding protocol involved over here. This is possibly due to an occlusal overload. Why? Because it is seen on the occlusal surfaces. So when the upper cusp is continuously stomping over the lower crown and there's an occlusal overload which has not been adjusted, eventually that 1.52 mm chip of porcelain will completely wear off, right? If this was a monolith crown, it would have not happened. A monolith means something that has been milled out of the entire one block. Then this would have not happened. But the reason here for this is an occlusal overload that has led to the chipping of porcelain. Now, if they show you a video showing mobility, right, then that would be something relevant to D, but then that will be a very straightforward question. It can possibly lead to mobility in future of the crowns if the lower load is not corrected. So possible complication is that, but it is not visible here in the image. So option D goes out of the picture that way. What is visible is a chipping of porcelain and your reason for that is occlusal overload. Now question number 9, best finish line for a metal crown is what? Feather edge, shoulder, chamfer, bevel. I think all of the questions here try to convey the same thing here. You can even use a feather edge for a metal crown, but what is the best one? It is chamfer. So when we have a chamfer, it will be like this. Internal angle is generally rounded. Fine. The chamfer goes about like this. Generally, what we prepare is a 0.5 millimeters of chamfer that we prepare for a metal crown, and universally the most commonly used and accepted is chamfer. So what we follow is chamfer for metal and shoulder for porcelain or ceramic. There's a reason for it. Material properties are responsible for it. Porcelain being a brittle material, at least requires a strong shoulder of 2 millimeters, and that is why you use a shoulder over there. Metal can be very nicely burnished and adapted. That is why you use a chamfer for it. So question 9, correct answer is option number C over here. Now, let us come to question number 10. Localized soreness after denture relining is most commonly due to what? Now, one thing which we need to stress upon over here, which can lead to our answer, is localized and relining, right? Relining, one of the more common complications or other two common complications with relining are, first, your occlusion is affected. Second, possible overextension is there. But when the word localized is mentioned, then probably there is an occlusal overload at some point. and it has led to an occlusal prematurity, which is leading to that soreness. If there is a generalized soreness after relining, I will say there is an overextension, right? So localized soreness after denture relining is more commonly due to an occlusal prematurity that is coming at some particular point, which is constantly leading to pain and tenderness. So correct answer here is option number C. It is a tricky question, but read your question very carefully. If it is a generalized soreness, I'll consider overextension as the answer. Question 11. Advantages of CAD CAM dentures include what? Improve in fit? Yes, definitely. Reduced porosity? Yes, again. Increase in polymerized shrinkage? No. Better reproducibility. So 1, 2 and 4 is the correct answer. So A, B and D. They offer better fit. They will have reduced porosity. They have better reproducibility, because all of these procedures they are designed. This is a computer assisted designing, and then there's a milling. It's not a standard processing that you do in a flask, which will incorporate a lot of shrinkage and other factors. So CAD CAM offers that advantage, and definitely pricier than a standard denture, but these advantages are there. So 11th question, option A answer, quite easy. Now, surveying, one question. Purpose of cast tilting is what? So first step of surveying that involves is to adjust the tilt of the cast to find what? The most favorable path of insertion, but specifically for what? To locate favorable undercuts. So as you can see in the image over here, the cast has been tilted significantly anteriorly. That is how it has become parallel to this particular wall of the premolar, right? But then when it comes over here, right? When it comes over here, then this angle becomes too much. So we have to adjust the tilt of the cast in a manner where all of your proximal surfaces that are going to be touched by the rigid component of the cast partial denture require minimal tooth preparation, and they come near parallel to each other. We adjust that particular tilt in the first step of surveying, and this step is called as to locate your favorable undercuts, which is our first step in surveying. So option number B is your correct answer here. Now question number 13, most common cause of porcelain fracture in PFM crown is what? A thermal mismatch, occlusal overload, cement failure, or metal corrosion. We saw it in our previous MCQ also. Generally, it is an occlusal overload that can lead to your most common porcelain fracture in PFM crowns. Cement failure, corrosion, and thermal mismatch are responsible for it, but not as significantly as an occlusal overload. And I think this will be our last question. Primary role of rest in RPD is to improve aesthetics, retention, vertical support plaque, straightforward textbook line and question. Something that we begin our rest video is, rest is responsible to provide vertical support. Now, what exactly is support? For example, this chair that I'm sitting on, it has 4 legs. So the purpose of this chair is to take my weight and transfer it to the underlying surface. This property where you absorb the load and transfer it to the underlying surface, this is called as support. The rest does exactly the same when prepared on the occlusal surface of the tooth, which will be the most favorable rest, which is an occlusal rest. It takes the vertical load and dissipates it to the underlying tooth through the PDL, goes finally to the bone. That is the primary role of a rest, right? So this brings us to an end of the discussion of NEET GT12. As always, if you have any questions, doubts, queries, or suggestions, please put them in our Telegram group. We'll be more than happy to solve it for you. Thank you.